stomach. So let's start with stomach. So where do we see the stomach? See, basically in the abdomen we have 9 regions as the lines are representing here. So what are the various 9 regions we have? See, this is right hypochondrium below the ribs. This is epigastric. This is left hypochondrium which is below the left ribs. This is umbilical region. Okay, so this is right lumbar region, left lumbar region. This is hypogastric region which is written as pubic, and then we have like right iliac fossa we usually use in our books, and left iliac fossa. So right flank, left flank word we usually use right lumbar and left lumbar, and right iliac and left iliac for either side of this groin region which has been named here. So if you see these 9 regions of abdomen, so where is the stomach present? So the stomach is present in the left hypochondrium and epigastrium. So if you just look at this picture, it also gives us an idea like where exactly stomach is situated. What are the anterior relations? So the anterior relations of the stomach are, we have studied liver day before yesterday. I told you we have right and left lobes, and this is the inferior border. Okay, and this is the point for falciform ligament. So the stomach is covered by a part of the right lobe and completely the left lobe of the liver. Okay, and if you remove the stomach, whatever things you see behind, you call it as stomach bed. Okay, so now see here, the presenting parts of the stomach are, stomach is in continuation with esophagus, and the part of the stomach in continuation with esophagus you call it as cardiac orifice. Okay, so this is like, and the part of the stomach which is in continuation with duodenum is the pylorus. Okay, then so the other presenting parts of the stomach are, this is lesser curvature and this is the greater curvature of the stomach. If you draw one line from the cardiac end of the stomach, that is in continuation with the esophagus, if you draw one line touching it to the greater curvature, so whatever area which is above is called as fundus, below that you have body. The name fundus and body we also use to represent uterus, which we have already studied, isn't it? Now, if you just look at this lesser curvature, it shows it is little deeply angulated. The point of deep angulation, again, if you start one line and if you allow it to cut to the greater curvature, so the area below this is actually called as pyloric antrum, okay, the pyloric orifice. So, and the deeply angulated area is called as incisura angularis. Incisura angularis. So we have two orifices. This is cardiac orifice and pyloric orifice. Cardiac orifice in continuation with esophagus, pyloric orifice in continuation with the duodenum. Okay, so fundus, body and pyloric portion. The pyloric portion has pyloric antrum, pyloric canal and the pyloric sphincter. Okay, so this is the cardiac like notch, and we have angularis, incisura angularis. Okay, then the presenting parts are, the stomach is placed in such a way in the abdominal cavity like it has anterior superior and posterior inferior surfaces. Okay. Now coming to the anterior superior surface of the stomach, it is completely covered with peritoneum. The peritoneum is reflecting from the liver. If you remember my previous classes, I told you like we have greater sac and lesser sac. Basically, stomach will have a covering on the lesser omentum. We have lesser sac, like lesser curvature of the stomach will show the attachment of lesser omentum, and greater curvature of the stomach will have the attachment of greater momentum, isn't it? So that's the reason, like anterior surface or the anterior superior surface, which is shown in the form of a dotted line over here, only a part of stomach is seen. It is completely covered by peritoneum, and anteriorly it is related to greater sac. Okay, so this area is also related to left lobe of the liver, and it is related to which ribs? See, on the left side, 6th, 7th, 8th, 9th ribs and their costal cartilages. Okay, and we know there is a partition between the thorax and abdomen, that is diaphragm, isn't it? So basically the diaphragm is actually separating it. The stomach is separated from the left lung and left pleura by the left dome of diaphragm. Not only that, in the middle you are seeing heart and pericardium also. So superiorly, the stomach is separated by this diaphragm. It is also separated from the heart and the pericardium. So what are the various things you are finding here? So diaphragm is separating it from the base of the left lung, then left pleura, pericardium and heart. Okay, and anteriorly it is also related to anterior abdominal wall. So all these are the anterior relations. This picture will help us to understand very clearly. Okay, stomach bed is very popular question. If nothing is asked from stomach, we may get a 5 marks question as stomach bed, or we may get a 3 marks question as a stomach bed. So what is that stomach bed? So if you remove the stomach, then whatever structures we find in the bed region, that is actually the posterior inferior relations of the stomach. So that means here only outline of stomach is given. If you see, this is the outline of stomach, which is a bold black line. So behind that, whatever structures we are finding, you are finding central tendon of diaphragm here, we are finding spleen, we are finding pancreas, we are finding left kidney, left suprarenal gland, we are finding celiac trunk with its splenic artery. Okay, the splenic branches entering into the hilum of spleen. Okay, we are also finding the part of portal vein, common hepatic duct, then gastroduodenal artery. Behind the portal vein, we are finding inferior vena cava. This is transverse colon, and I always tell you, like, the word meso is used to represent peritoneal fold. Hence, the fold of peritoneum suspending transverse colon is transverse mesocolon. So, whatever outlined areas, whatever things we found, okay, so these are all actually helping us locate the stomach bed. So let us see. So stomach bed, like posterior inferior surface of the stomach is also covered by peritoneum, and we know behind the stomach whatever area is there, we have studied already lesser sac as 5 marks question. Okay, so now what are the things we have? Like posterior inferior surface, we have diaphragm, left crus. Okay, so it is related to spleen. This is left kidney, this is left suprarenal gland, we have this is the splenic artery, pancreas. This area blue in color is transverse mesocolon, and this is left colic flexure. Okay, so whatever has been listed and whatever has been shown here is nothing but stomach bed. Okay, now see here, this is the lesser curvature of the stomach. From the lesser curvature of the stomach, you have lesser omentum. Lesser omentum is going and it is attaching to the porta hepatis area of the liver, isn't it? So porta hepatis, already we have studied visceral surface of the liver. So if you remember, I told you porta hepatis contains VAD structures, portal vein, hepatic artery and bile duct, isn't it? This is the left free margin, right free margin of the lesser omentum, where we have an opening. This also we already did, that is epiploic foramen, also called as foramen of Winslow. So foramen of Winslow is actually communicating the greater sac which is present in front to the lesser sac which is present behind. So epiploic foramen is a communicating point. Okay, so this is now this is our greater curvature of the stomach. So on the greater curvature of the stomach, you are finding a very big peritoneal covering. So this very big peritoneal covering is greater omentum. Now, when you see the peritoneal coverings of the stomach, let us see certain modifications. So, lesser omentum is thickened between the liver and also the stomach. You call it as hepatogastric ligament. Hepatogastric ligament. Similarly, there is a thickening of this peritoneal covering between the liver and first part of the duodenum. You call it as hepatoduodenal ligament. So, we have hepatogastric ligament, one thickening, and hepatoduodenal ligament as one more thickening. Okay, then we know, like, this whole thing whatever we are seeing on the greater curvature is greater omentum. So this greater omentum is also showing certain thickenings. So from the greater omentum to the spleen, we have one thickening. You call it as gastrosplenic ligament. Gastrosplenic ligament. So there is one thickening between this greater curvature of the stomach and transverse colon. You call it as gastrocolic ligament. Okay, So overall greater omentum is actually, it's a very big peritoneal covering which is hanging in the peritoneal cavity and which covers the abdominal cavity like a big apron. Okay, so that is omental apron. Now when you just know these peritoneal coverings, now we are going to the interior of stomach. When you just cut open the stomach, you will see inside. Basically, when you see the histology of stomach, it has four layers. When you see from inside to outside, we have mucosa, submucosa, muscular layer, and serosa. So the mucosa is showing so many folds, which are actually called as rugae. When we have studied peptic ulcer in physiology, I told you along the lesser curvature of the stomach there is a canal which is directly connecting the lesser curvature of the stomach to the first part of the duodenum. So that canal is called as gastric canal, also called as gastric canal of Magenstrasse. Okay, so the fluids or liquids or alcohol or whatever we drink, the soft drinks, whatever beverages, carbonated drinks, they usually do not go along the complete lumen of the stomach, but they travel along the lesser curvature through the gastric canal directly connecting to the first part of the duodenum. That's the reason lesser curvature of the stomach and first part of the duodenum are prone for ulcers. Okay, and the gastric ulcer plus duodenal ulcer, together we use the word peptic ulcer. So this thing we have studied in physiology, and again I am repeating in anatomy because you are supposed to write this point as well. So these mucosal folds, whatever we find in the interior of stomach, they are called as rugae. The purpose of rugae is they are actually increasing the surface area of the stomach. So that means wherever we have folds, if you uncoil these folds, the surface area is more. That means these rugae are actually increasing the surface area so that maximum amount of food can be accommodated in the lumen of stomach. Okay, so that is the purpose of rugae. These are all gastric rugae. When you just look with hand lens, okay, so basically this gastric rugae will show small holes. Those small holes are nothing but gastric pits. So gastric pits are nothing but the areas of the openings of gastric glands. So when we see the histology of stomach, of course I will discuss the histology as a part of histology question when it comes. So gastric glands will be opening in the mucosa. So those openings are called as gastric pits. So the purpose of gastric pits is to pour the gastric juices. So gastric juices will be entering into the lumen of stomach and it will be helping with the process of digestion. Okay. Now after that we will know the blood supply of stomach. So the blood supply of stomach comes from celiac trunk. So from the celiac trunk we have three major arteries. So what are these three major arteries? You see here, one direct artery we have is left gastric artery, which is moving along the lesser curvature of the stomach. Then we have one big artery which is called as splenic artery, which is going behind the stomach. In the stomach bed we saw pancreas, isn't it? So basically at the upper border of pancreas we find this splenic artery. That is the second branch coming from celiac trunk. The third artery we have is the hepatic artery. Okay, from all these three arteries we will see the blood supply of stomach is coming from. Okay, celiac trunk gives three main arteries. One is the left gastric artery, second is splenic artery, and the third is hepatic artery. So left gastric artery is the direct branch which is supplying the lesser curvature of the stomach. Splenic artery gives many branches. Okay, what are the various branches it gives is left gastroepiploic artery, which forms an anastomotic network along the greater curvature of the stomach, which actually anastomoses with the right gastroepiploic artery. Right gastroepiploic artery is a branch of gastroduodenal artery. Gastroduodenal artery in turn is a branch of hepatic artery. And from the gastroduodenal artery, we also get right gastric artery. So to summarize, on the lesser curvature, we have right gastric artery coming from gastroduodenal artery, which in turn is a branch of hepatic artery. We also have left gastric artery, which is a direct branch from celiac trunk. So left gastric artery and right gastric artery will anastomose on the lesser curvature of the stomach. Then left gastroepiploic artery is a branch of splenic artery. It anastomoses with the right gastroepiploic artery, which in turn is a branch of gastroduodenal artery, which in turn is a branch of hepatic artery. So these are the main branches which are supplying the stomach. Apart from that, you see left gastric artery is also giving like small branches which are actually supplying the esophagus. Now if you observe from the splenic artery, we also have short gastric arteries supplying fundus of stomach. Okay, so all these this well labeled diagram you are supposed to draw. This diagram is given in Chaurasia, in Vishram Singh, whichever book you are following. That is fine, don't change the book now. Draw the diagram and write the answer in your own words. Okay, so again here in this picture also we are seeing from the abdominal aorta celiac trunk is shown. This is left gastric artery. This is splenic artery which is running on the upper border of the pancreas and going into the spleen. Okay, and this is our hepatic artery. This is gastroduodenal. Right gastroepiploic, left gastroepiploic. We have right gastric, left gastric, short gastric arteries. All these arteries are supplying the stomach. Okay, the artery is running along lesser curvature. Left gastric, direct branch from celiac trunk. Right gastric, it's a branch from common hepatic artery, which in turn is a branch of celiac trunk. Along the greater curvature, we have right gastroepiploic and left gastroepiploic. Left is a branch from splenic artery, right is a branch from gastroduodenal artery. Short gastric arteries are also the branches from splenic arteries. So very nice explanation already I gave you. So this is for the blood supply of stomach. So correspondingly to the arteries, we have veins. You call them as like a venous network. We have various veins like left gastric vein, we have right gastric vein, we have short gastric veins, left gastroepiploic vein, right gastroepiploic vein. All these veins will be draining into portal vein. Okay, splenic vein will receive, we have studied portal vein as a short note. Of course, we will be studying as essay in future classes. See here, this is splenic vein. Into the splenic vein, inferior mesenteric vein joins. Okay, and this is the actually we have superior mesenteric vein and splenic vein will join to form portal vein. So into the portal vein, left gastric vein, right gastric vein. Okay, so many veins are draining. Okay, so veins of the stomach corresponding to the names of arteries, you can draw the veins in the same place. Okay, left gastric vein, it drains into portal vein. Right gastric vein also drains into portal vein. Short gastric veins, they drain into the splenic vein. Okay, left gastro and right gastroepiploic, left gastroepiploic vein drains into splenic vein. Right gastroepiploic vein drains into superior mesenteric vein. This is our superior mesenteric vein position. Now, after studying the arterial supply venous drainage, now we will go with the lymphatic drainage of stomach. So lymphatic drainage of stomach, we have certain group of lymph nodes. We have left gastric group of lymph nodes. We have right gastric group of lymph nodes. Okay. Then right we have left gastroepiploic and this is the left gastroepiploic. Then we have right gastroepiploic lymph nodes. We have hepatic group of lymph nodes. Okay, and we have celiac group of lymph nodes. Along all the names of arteries, gastroduodenal group of lymph nodes and pancreatico-splenic nodes. So the names see along left gastric artery, left gastric, along right gastric artery, right gastric lymph nodes. Along left gastroepiploic artery, we have left gastroepiploic lymph nodes. Along right gastroepiploic artery, right gastroepiploic lymph nodes. So names of the lymph nodes are in correspondence to the names of arteries. Finally, you see the short gastric nodes, the splenic nodes, they are, you can see the direction they are coming towards the celiac group of lymph nodes. Left gastric also move to celiac group of lymph nodes. Gastroduodenal also move towards celiac group of lymph nodes. Isn't it? Right gastroepiploic and gastroduodenal nodes, they are draining into hepatic. Finally, hepatic lymph nodes also will drain into celiac group of lymph nodes. Okay, in your textbook also similar type of explanation is given. You should understand the concept. So lymph from all the direction is moving to celiac group of lymph nodes, which is situated around the celiac trunk. Okay, that is. So we have seen everything. Now coming to the nerve supply. So nerve supply of the stomach comes from vagus nerve. Okay. So sympathetic fibers, they actually form the celiac plexus. Okay. So sympathetic fibers, they are derived from C6, C7, C8, C9. That means uh, thoracic sympathetic spinal segments are coming from T6 to T10. Okay, so they form a celiac plexus. Okay, they reach the stomach around gastric and gastroepiploic arteries. They are vasomotor. That means they are actually carrying the pain sensations from the stomach. Okay, the sympathetic fibers. The sympathetic fibers are derived from T6 to T10. Parasympathetic is always vagus nerve. Okay, so the vagus nerve, it is actually dividing into anterior vagal trunk and posterior vagal trunk. You can see here. Anterior is shown in bold lines and posterior is shown in dotted lines. Okay, so anterior and posterior gastric nerves are the branches of vagus. Okay, so they actually are motor to the muscle wall and inhibitory to the pyloric sphincter and secretory to the glands. Okay, so suppose if gastric secretions are more, see what do we do? We generally see it is supplying the glands, no? So generally we cut the part of vagal trunk so that excessive HCl is not released in the stomach. You call that procedure as vagotomy. Vagotomy. When we don't want excessive gastric secretions, when you want to stop the HCl secretion, we generally cut the vagus nerve. Okay, that is vagotomy. Okay, so surface anatomy is not required, beta. So generally we usually do this barium meal. This is generally kept in your x-rays also. So barium meals means what? We generally give barium meal through the mouth. The barium, it is something like Colgate powder mixed in water. Okay, it test looks like that, the barium meal. And we ask the patient to swallow it, and we will just wait for 1 to 1.5 hours, and it passes through the esophagus and enters into the stomach. We will generally check whether the stomach is normal or if there is any obstruction, if there is any cancer in the stomach. We can all rule out with the help of radiograph, that is x-ray taken after barium meal. Okay, where you are seeing the body of stomach. So this is the commonest type normal x-ray we find after barium meal. See here, one is representing esophagus, two is representing fundus of stomach, three is representing body, fourth is lesser curvature, five is greater curvature, isn't it? Sixth is pyloric antrum, seventh is pylorus, and eighth, the duodenal bulb has started. This is all duodenum. First part, second part, third part of the duodenum. Okay, that means radiograph has nicely descended down. So what does it mean? That means stomach is normal and there is no obstruction in the stomach. Okay. So this is all radiological anatomy. And to continue, the barium meal has also entered into the small intestines. This is completely duodenum. These are jejunal coils. Okay, this is the duodenojejunal flexure. Okay, so that finishes stomach. So about stomach, you can also talk about things like what are the other things we have? Gastric ulcer, peptic ulcer, gastric carcinoma. Okay, so all these things you can do in the stomach. So what is our next question? Inversion, eversion, isn't it? Okay, so lateral compartment muscles we have to check, and also nerve supply. That means we have to go with peroneal nerve, common peroneal nerve. Okay, so I think the link may go in less than 1 minute. I will share the link again. Okay, meanwhile I'm opening the PowerPoint. Meanwhile, read stomach, the most probable essay question. The examiner doesn't want to trouble you, he will frame an easy question. Person comes with epigastric pain. Okay, so there will be given some hints which will represent gastric ulcer. So then you will be asked to write the gross anatomy of that particular visceral organ. Okay.